Pick up where we left off. We were interrogating common sense and explaining that that interrogation of common sense included some tough questioning of even our very respected, quite admirable textbook authors, Shi and Singh. I point out that I would agree with 95 or something % of what they write as astute, well-formulated, well-researched. But I have questions about things from time to time, and one of the questions I have has to do with their reference to the Fraser Institute in Canada on page 22 in the context of raising questions about queuing times, people lining up long time for service in national health programs, generally using the example of Canada's as just one instance. So according to Canada's Fraser Institute, blah, 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 there is a problem here. This is on page 22, the left column about 3/4 of the way down. So we have to interrogate this. We have to look at this. The Fraser Institute is a private entity in Canada. It is not the Canadian Health Department or Ministry, whatever it is officially called. It is not a body equivalent to the Kaiser Family Foundation and their health reform website, which is the most thorough and respected source of information about health reform, about how the Affordable Care Act is going in all its dimensions, which is universally regarded as a very high quality with very robust and carefully analyzed data. Is that what the Fraser Institute is, or is it some other kind of entity? And if it is another kind of entity, why do the authors quote it with such respect and authority? Is there some kind of funny business going on here? In class, when I raised this question at the very end on Wednesday last week, a couple of people raised their hands and began to quiz. What's the Fraser Institute? What about it? And I wonder if any of you have followed that up. There were a couple of people who raised the question immediately, and I wonder if those of you who either raised your hand and raised the question or others have looked up the Fraser Institute. Anyone? Yes, and what did you find out?
So it's, I did come across research, it's a conservative think tank, sort of policy guiding institute.
So it's not a neutral body. It is a conservative think tank. Aha! Your high alert should be on. Let's pursue that. Anything else to add to that?
No, I don't.
Okay, well maybe we consulted some of the same sources. The first sentence of one of the sources that I find most trustworthy in this regard is the Fraser Institute is a Canadian think tank. It has been described as politically conservative and right libertarian. In other words, it's not neutral. It's a body that might accept the ideology of Rand Paul or something like that. It has a very definite political position, and it presumably uses its resources to support that position. Well, what else has it done? Forbes magazine has referred to the think tank as libertarian. The New York Times described the Institute as conservative. The Calgary Herald, Calgary, Canada, called it conservative. The Langley Times classified it as right-of-center libertarian, while humanist philosopher Kai Nielsen referred to the Fraser Institute as an extreme right-wing libertarian think tank. Yet it was cited in our textbook as if it's just a neutral source whose opinions are to be trusted and whose data is to be accepted without further scrutiny. Something weird is going on. This is what happens when you interrogate common sense and why you must do it of every possible source, including me. Okay? I should be subjected to the very same treatment if we respect this principle of interrogation. A little bit more from this account of the Fraser Institute. According to journalist Murray Dobbin, 31% of the Fraser Institute's revenue comes from corporations and 57% from business-oriented foundations, such as the right-wing Donner Foundation and the free market-oriented John Dobson Foundation. In addition, a report stated that the Fraser Institute received $120,000 in funding from the oil giant ExxonMobil. During 2000-2010, the US-based Charles Koch Charitable Foundation and the Charles R. Lamb Foundation, both under the billionaire brothers Charles and David Koch, provided $500,000 to the Fraser Institute. If any of you have been following U.S. politics in recent years, have listened to anything Bernie Sanders has said, and know about the way in which money is distorting our political system, in which billionaires defending the coal and oil industry have tried to get into the debate and question environmental science and so on, you'll know that money from the Koch brothers is at least a little suspect. And yet a significant portion of the Fraser Institute budget comes from the Koch brothers. The Institute is well known for its annual Economic Freedom of the World Index, which ranks countries according to their degrees of economic freedom, which I presume means lack of government regulation and oversight, complete free market principles in operation. Waiting Your Turn, Wait Times for Healthcare in Canada, is the Institute's annual report on waiting times. So coming out of this same nexus of influences, of sources of revenue, and of political ideology and orientation comes their report attacking the Canadian health system. Is that a surprise? Shouldn't be. Is their finding, therefore, objective data that should be given the same respect as if it came from an unimpeachable source? Absolutely not. Why do our smart authors quote this? Perhaps because they, in some subtle way, or not so subtle way, share some of the bias of the Fraser Institute. Not even our quite respectable, highly regarded textbook is free from interrogation and scrutiny. Here are some of the things the Fraser Institute supported. It had published a number of articles and statements opposing Canadian gun control laws, which in much of the world are respected by contrast to the US so-called gun control laws. As we all know, our gun policy is controlled by the NRA and the people who support them. According to an article published in the CBC News Online, some people allege that Michael Walker helped set up the Institute after he received financial backing from forestry giant Macmillan Bloedel, largely to counter British Columbia's left-leaning government. The Institute has been criticized by trade unions for its recommendations in the labor market. So it has a consistent set of policies. And here's another one, if you were not convinced yet. The British American Tobacco Company funded a good deal of the Fraser Institute's research. The Institute in 1999 published something called Passive Smoke, The Betrayal of Science and Policy, which highlighted the absence of any scientific evidence, they claim, for linking cancer with secondhand smoke, and received widespread media coverage both in Canada and the United States. At the time, the CEO of British American Tobacco and its Canadian subsidiary was also on the Fraser Institute Board of Trustees. All right? The Fraser Institute ceased disclosing its sources of corporate funding in the 1980s, and in 2000, the Institute published under in an industry-friendly paper, A History of Tobacco Regulation, which criticized tobacco regulation and made it seem silly. The Institute has been criticized by health professionals and scientists for sponsoring 2 conferences on the tobacco industry entitled Junk Science, Junk Policy, dismissing all the epidemiologic evidence about the relationship between tobacco and various health issues, and Managing Risk and Regulation, Should the Government Butt Out, B-U-T-T, the pros and cons of tobacco regulation. But critics charged the Institute was associating itself with tobacco industry's many attempts to discredit authentic scientific work. Maybe a little bit like the Koch brothers trying to discredit legitimate environmental work, etc., etc. So the Fraser Institute is at least suspect and should not be quoted as an authoritative source without further commentary, or at least a footnote indicating some people will dispute these findings, but they quote it as authoritative. That's bad. Yes?
What did the Koch brothers do environmental again?
They have spent an enormous amount of money lobbying for any attempt to have environmental, what's the Trump administration has done, gutted the EPA. They have cut back the EPA has at its head someone who is opposed to environmental regulation. It's the equivalent, and a lot of the Trump appointees are like that, It's equivalent to pointing, as you know the phrase, pointing the fox to guard the hen house. You're supposed to have someone who is at least neutral or supportive of whatever scientific evidence exists about possible dangers, rather than trying to roll that back because they want to advance their own business interests, which are in coal and dirty energy sources. So we have to then question this statement that national health programs, Canadian health program as an example, naturally have queuing times that slow people down and are a negative, a bad mark on national health programs. Well, what are some other issues that can be raised in this context besides the questionability of the Fraser Institute's reliability as a source of information? What about wait times in the US? And wait times in the US for people who have very good health insurance, like the universities provided Excelis Blue Cross Insurance, etc. You can wait sometimes 6 to 9 months for an orthopedic appointment, depending on the specialty. If you make an appointment with your primary physician, you may have to wait 4 to 5 months if it's a regular checkup. And when you call your primary physician's office, every single medical office in Rochester I called has an automatic announcement which says, if this is a true emergency, go to the emergency room. We don't want to see you. If you're calling for an appointment, push 2, or whatever it is. And then you find out that you're 4 months out or 5 months out from a regular appointment, so maybe the emergency room, etc. That's how it goes. That's in the American system. Wait times are not absent here, and the only people who can push consistently to the head of the queue, those who have enough resources so they can buy their way to the front, but those regular folks who get their health insurance through employment, even if it's good health insurance, have to wait a very long time, and it depends on the particular area in which you're looking. There are clear budget connections between any queuing problem. Let me think of a very simple example that maybe you've all experienced in one time or another. If you've been to Wilson Commons, to the pit, to get lunch during peak hours, sometimes there are 4 registers open. So even though there are long lines, you move quickly through them, right? Sometimes, though, even during peak hours, only 2 registers are open. Or, in the worst case, 1 register with lines snaking all around the pit. Why? That's a budget consideration. Assuming everyone was healthy and was able to report to work that day, managers of pit decided that, well, we'll save a little money. Instead of paying 4 people to do this concurrently, we'll pay only 1 or 2 people. And every time you make a budget decision like that, based on what you estimate to be your financial or economic reality, we have a limited budget we have to spend. So people will wait a little bit. It'll be a little inconvenient, but no big deal. Throw money at the problem, open up all 4 registers, the queuing problem goes away. And it's the same thing in a health system. It's the same exact economic principle. Queuing is a function of budget. And if budget were changed or reallocated or differently prioritized, the queuing problem would go away. And there is clear evidence of that in Canada. One of the major queuing problems existed about cardiovascular disease in the province of Quebec. Quebec looked at the data, decided they were going to put some money on the table, and lo and behold, the wait times for cardiovascular care in Quebec went down considerably. It's a financially related issue, and it's also a politically related issue. The politics of the Canadian health system, like the politics of any health system, are complicated. In Canada, it's particularly complicated because the health is provided by the provinces, but there's a shared financial arrangement with the federal government. The federal government that is located in, I'm now suddenly blocking on the name of the capital of Canada. Ottawa, yes, Ottawa, which is confusing because it's in Ontario, but it's also a very francophone city, etc. And that's one of the reasons, I suppose, the Parliament is there, because Canada is officially a francophone country, although that applies mostly to Quebec and Ottawa, I suppose. Anyway, if there's a tangle between the government based in Ottawa and the provincial government wherever in the provinces of Canada, because they have different political commitments, different political parties. There's going to be a struggle, and resources might be withheld. There are also patterns of Canadian politics, just like American politics, where you have sort of an arc of liberal prime ministers. We do have one now, followed by conservative, and so on. The alternation continues. If it's a conservative who's in charge, he will have different views and priorities than a liberal, and they will have different tangles with provinces depending on whether the province is led by a liberal or a conservative. We know already what can happen in tangles between federal government policy and state policy, and we may be heading for some very dramatic confrontations between the Trump administration and two states on different coasts which have very different views and very different politics. New York, California, where the governors of each have proclaimed a war against some of Trump's policies. Sanctuary cities, for example, and other sorts of things, with threats from the Trump administration to punish them. These are tough battles. It's not clear how it will be worked out, but in the process of fighting these battles, even if they're very different perspectives, it's quite possible that the national administration will pull back some of its resources that would normally go to the state, even though the state contributes a significant part of the overall national tax revenue and doesn't get back any part of what it actually contributes. Similar things can be going on in Canada. And so you have to look at any purported example of wait times and try to get behind it, assuming that it's real and not cooked up data or distorted data because of the political bias of those who are putting out the data, but assume that it's real. Where are we in the political cycle? Do we have a liberal or conservative prime minister? Is he trying to clamp down on things? What province is this happening in? Is there a struggle between Ottawa and the provincial capital? And what's going on there? A lot of the problems surface in Quebec. And Quebec is a francophone province which has often claimed that they want to become independent and establish their own separate national identity, not related to the rest of Anglophone Canada. Will someone of Anglophone tendencies and political and conservative political orientation try to punish Quebec by limiting certain of its budget allocations, and will that have an effect on the health system? You betcha. So even if there are wait times, and even if there is an alleged queuing problem or an alleged fleeing problem, people who are stuck in the queue flee to the United States to get care, we have to look to see if that's one, real, and two, if it's real, what causes it, without assuming that it's built inherently into the structure of the system. There is nothing wrong with a lunch counter system that has open registers. The problem is how well funded that register attendance issue is, whether there are 4 people to allow an even flow or only 1 to allow a backup that creates a backup. Those are the realities that you have to consider without immediately saying, well, it's an inherent problem. We'll come back to these issues when we look at international comparisons and at other times. But right now I want to shift to something that Shi and Singh say, which I think is absolutely unquestionable and needs to be pursued further. What they say is, if you look at the advanced countries in the world and you look at their national health systems, you will discover that the vast majority of them, with the exception of England, Sweden maybe, and a couple of others, which move more in the direction of a national health service, that is of salary physicians or physicians paid on the equivalent of salary by the per capita number of people in their practice, and centrally budgeted hospitals. By and large, most major countries, France, Germany, Switzerland, etc., have health systems with the same fundamental components as the United States. They have largely not-for-profit or voluntary hospitals, often associated with medical schools or teaching and research institutions. They have physicians who practice in their office and take all kinds of patients, and so on, just as we do. Just as we have patients who sometimes come to a regular doctor's office or a hospital with Medicare insurance because they've qualified for it by reaching the age of 65 and going through the sign-up period and so on, then those patients are mixed and mingled in the waiting room with patients who have their health coverage through Excellus Blue Cross or private pay or whatever, all in the same office. And it's the same thing in most advanced European countries. But most advanced European countries have what we do not have, which is a national health insurance system. Their national health programs around the world, in most developed countries, are provided by a NHI, a National Health Insurance Program, which is either run directly by the government, which would be the case if Bernie has his will, and we get Medicare for all in this country. We have Medicare for those over 65, and a few other people in other categories who qualify. We'll get to some of those exceptions later. But instead, apply it as Bernie would now like to see happen, and 15 senators have endorsed this legislation with him, to have it spread through the lifespan. So you don't have to wait for that particular age in order to qualify for a government-run insurance system. Not a government-run health system, but the government collects the revenues, allocates them, negotiates with hospitals and physicians about reimbursement rates, and all that sort of thing. That's what happens in most developed countries that have a national health program. The national health program is a national health insurance program. This began as a historical phenomenon in the late 19th century. And it began for interesting political reasons. It really started in Germany under Chancellor Bismarck in the 1880s and proved successful, and then spread from Germany to other countries on the European continent, and jumped the channel and spread to England in the early 20th century. And at that time, there were Americans who knew the European system and were trying to promote its spread in the United States. The beginning of our first battle for a national health program goes back more than a century. Goes back to the early 20th century, when certain leaders of health policy in the United States, schooled in the methods of Europe, seeing their success, wanted to promote them and advocate for them, and had some success doing that in the United States. That's a long, complex, checkered history, which we will be looking at directly soon. For now, let's just look at some of the starting circumstances in the European countries. There were political motivations. There were struggles for power and authority between representatives of the working class, unions, parties on the left, with their employers, with the owners of the manufacturing plants, the mines, and the foundries, and the like. And that struggle led to tremendous political tensions in late 19th century Europe. One of the brilliant stratagems invented by the very conservative Bismarck was to create a national health insurance scheme. It happened in stages, to create a base of security for workers who were getting radicalized because they had nothing left to lose. If you were a worker in late 19th century Europe and you lost your job because the factory closed or because you were displaced by a younger, more physically robust worker or whatever, you had no recourse. There was no unemployment insurance, there were no retirement benefits, there were no workmen's compensation laws. You depended on your salary working in that manufacturing plant for your survival. You depended on that salary to pay for your family's rent, food, clothing, basic needs. And if that salary were cut off for whatever reason, you were stuck. And if you were stuck, why not join some group that said, we're going to overthrow this government and take the resources into our own hands because that's the only way workmen will ever get what they deserve? Why wouldn't you join the ranks of a radical movement? And Bismarck, who didn't want to see that radical movement, who opposed it, was smart enough to know that repression alone wouldn't work. The more you try to put something down, the more it pops up. So you have to give the workers something. You have to give them something that they would now feel some loyalty to a state which they've seen only as their enemy, as the friend of the manufacturers, not of the working men. And Bismarck was politically brilliant enough to know that that's what should be done. So we created the first system that became the basis of everything else, of what he called sickness insurance. It was sickness insurance, not health insurance, because the real danger of being unhealthy, of being sick, was that you lost wages. You needed to have replacement of wages for absence caused by sickness. You could be injured on the job, or you could be sick with some infectious disease that was spreading through the ranks of the laboring class. In any case, all you knew is that you were not strong enough to report to work, and that meant that you would face a catastrophic loss of income, and your family might perish. And so Bismarck, knowing the political tensions and the political realities, intervened and said the state will provide sickness insurance. It'll force the employers to chip into the fund. They'll pay something. The workers will have a little bit taken out of their salaries, and the state will add a little bit more. We'll create sickness funds, and we will pay, if a worker has a certified absence from work because of sickness, we will pay a replacement wage that will cover the family's needs for the period of sickness. Catastrophic loss of income. It wasn't called health insurance or medical insurance because in the 1880s, when this was coming in, there wasn't much expectation that if you went to a doctor, it would do you any good anyway. Medicine hadn't really crossed the threshold to modern scientific acceptability and clear evidence of its successful ability to reverse disease and make people better. Medicine was still very much questioned. So the transformation of the term sickness insurance to cover missing wages for sick workers to health insurance as something that would pay for medical care was a 20th century phenomenon. Only when medicine in the 20th century gradually got to be more respected and actually was able to do more things. Not at first. So it starts with sickness insurance, it's transformed in the 20th century to health insurance when medicine begins to catch up, and that's how the whole process began. In order to understand what's going on, I think we need to have some simple understanding of the basic structure of insurance. It's really a very, very simple scheme, and it applies to all insurance. Whether it be privately run insurance or whether it be government run insurance, it's the same basic thing. Yes, it can get very complicated, but the essence of it is extremely simple. You create an insurance pool. That is money that's available to legitimate claimants. In the case of late 19th century Germany, those would be certifiably sick workers who were part of the scheme and therefore deserve to have some resources removed from the insurance pool to help cover their needs during periods of sickness. So how do you create an insurance pool? This is just the simple bare bones. You put funds into it, and these are called generally premiums. And then you extract from it, when needed, benefits. Benefits can be direct service, benefits can be salary replacement, benefits can be whatever, okay? That's an insurance pool. What this does is give the individual who could never be sure when the next major blow will strike some sense of security because there is a pooling of risks. That is, everyone puts in. Only certain people are able to take out when they certify that they have legitimate claim on the benefits. So as an individual, you may be extremely lucky, and you put in, you put in, you put in, and you never get sick, so you don't need to withdraw. Is that a bad deal? No. It gives you tremendous peace of mind knowing that if there is an unexpected, unpredicted, unplanned for, unbudgeted, catastrophic event in your life, you can then claim legitimate set of resources. What you're doing then, this is a scheme for what would be called the socialization of risk. Instead of risk being individual, you are socializing it among all those who contribute to this insurance pool. Sure, many people put in a lot more than they ever get out. That certainly could be the case in a given year, though next year may be when they really need the socialization of risk. Lots of people put in more than they get out. Why is this a good scheme? Because you know that when your turn comes, when you do need it, you will have it available, and the system is built to help you in that time of need. It will give you peace of mind, and will, even if you spend 20 years contributing, getting nothing out, that 21st year could have absolutely broken you and ruined your family, you will then be able to be one of the beneficiaries to get benefits. That's all there is to it. It's a socialization of risk. But socialization of risk among the community of those who contribute to the scheme and abide by the rules is not the equivalent of socialism. In fact, we all know that insurance is very, very big and profitable business. It is one of the most profitable business areas in the United States and elsewhere. The people make millions and billions of dollars. CEOs can collect $25 million annual salaries plus stock options. How is this possible with socialization of risk? Because there's a little thing hidden in plain sight, down in this little corner. Let's just call it overhead. Overhead is the amount that those who run the insurance system say, we need to run the system. We need to have people who collect the revenues, who send dunning notices to people who haven't paid their premiums on time, who make actuarial calculations so we know how to set the premium rates, who investigate claims. Is this a legitimate claim? Should we send money? Etc., etc. So you need overhead for basic administrative function. But what's hidden in plain sight, because you know only what you're putting in, and you know that sometimes you're getting out, but you have no access to the overall flow of dollars, money in the system. You don't know whether you may be putting in $1, and even in the best instance, at most you get out 80 cents worth of benefits. And that 20 cents goes into overhead. So what is overhead really? Overhead is a difference between premiums put in and benefits drawn out, and it can be rigged in various ways. If it's an efficient, stripped-down, government-run system like Medicare, overhead is something like 3%. So for every $1.97 goes out in benefits, and all the people who run Medicare and do it very efficiently and effectively get is 3% of the overall budget, because that top salary is not $25 million. That top salary is whatever's the top of civil service grade, maybe $150,000 tops, no matter how much that person would be able to get in the private sector, because those people are committed to public service, and that's what they want to do with their skills. But another private enterprise, Prudential, Aetna, one of those, overhead is actually 20%. And the difference between the 3% or whatever it is that is required to run the system efficiently, process claims, etc., and make actuarial calculations about how the premium should be set, is then just the base. And there's another 17% that goes into big salaries, marketing campaigns, fancy corporate headquarters, shag rugs on the floor, etc., and make this a for-profit enterprise that's one of the stalwarts of the American economic system with traded stocks on the stock exchange. So socialization of risk is completely compatible with high-end, very strong, for-profit, capitalist organization of the insurance industry. And this is something which is hidden in plain sight, because people who pay in have no idea what's really going on there in the overhead, how much of their dollar contributed is actually coming back as benefits, if not to themselves, to others in similar circumstances. One of the things the Affordable Care Act tried to rein in was the amount of overhead commercial insurance companies could actually take out. An important set of Obamacare or Affordable Care Act provisions has to do with maximums that overhead can allow. Still, the Affordable Care Act is very much a pro-capitalist, market-based system. It is nothing like socialization of medicine, despite some of the rhetoric that has been thrown at it. It builds in, as a very strong part of the American health system, this for-profit insurance industry. But they try to rein it in. And as a trade-off for new customers, which certain of the provisions of the Affordable Care Act provide, they will allow insurance companies, they will require insurance companies to have some more rules placed on them about having to fund pre-existing conditions without charging extra premium, or about the limit to how much profit they can take out, what percentage of the take. And in exchange for that, the insurance industry until this time has generally gone along and saying, okay, quid pro quo, we'll allow those rules to be imposed, but you'll have to send us more customers, and that's what the Affordable Care Act also tries to do. We'll come back to the Affordable Care Act. Get the basic principles of insurance clear and under your belt. There are related concepts that we need to begin to understand about insurance as well. The two basic ways of rating premiums is based on experience rating or community rating. Some insurance is experience rated that you all have some familiarity with, and other kinds of insurance is community rated. Much of health insurance, if not all, is community rated. What's experience rating? Experience rating says that who you are demographically and what your experience has been, how you've lived your life, should be relevant to how much you should be charged to be part of this arrangement. Good example is car insurance. There are different rates depending on your demographic. If you are a 20-something single male, your rates are going to be higher than a 40-something married female, based on the good actuarial evidence that 40-something married females generally drive much more carefully than 20-something males by themselves. In part because those 40-something or 30-something females may have kids in tow in the back of the car. They're driving to soccer practice and back. They're going to drive much more cautiously, much more carefully. And the likelihood of them getting into accidents and putting damage into their car or to somebody else that the insurance company has to pay for is much less. And you can get data, and you can have actuarians who do this. They are the people who make these calculations based on data, and they say, well, for you, the rate is such and such, and for you, more risky person, the rate is different. That's experience rated. If we had health insurance exclusively on experience rating, there would be a complete physical exam, there'll be a complete scrutiny of the medical record, and depending on what your life history has been, whether you seem likely prone to illness or you run up expensive costs, then the premium would be set higher because it's only fair. If you are more likely to call upon the benefits, then you should have to pay in more. That's the basis of experience rating. So why should there ever be community rating? And why should community rating be so common in healthcare plans, especially those that are on the high end and are generally respected? Because something else can be accomplished by insurance through community rating. By the way, these terms and their applications are discussed in Shi and Singh, pages 200 and 201, and some other places as well, but that's a good place to start. Experience. Community rating is the way the University of Rochester and other large entities usually run their insurance. There's discussion of community rating in a number of places in the textbook. Let's see if I can find my notes about that. Well, the basic insurance concepts in general discuss pages 199 to 200, and I think 200 to 201 are probably among the most useful places to look. But let's talk about the University of Rochester and why typically it has decided to go for community rating. What that means is, as an individual, during the enrollment period, which is coming up about now, end of the year for next calendar year, you can choose one of several options of plans with different sort of categories of benefit and of copay and deductibles and so on. You can choose option A, B, C, or whatever. Once you've chosen the option, once you've chosen the structure of the plan, then the rate is the same for everyone choosing that plan. And let's suppose the rate is 7%. That's 7% of your salary. So if you're an assistant professor and making less than full professors, you will both pay 7%. The full professors will contribute more actual dollars because it's 7% on a higher base, but the faculty who are starting out, have lower base salary, will still be paying 7% of that salary. That's a community-rated system. You can say, for the younger people who are generally healthy and who will not be calling upon the healthcare resources to the same degree that the older faculty will. As they get older, there are more health issues. We know this is part of the risk of growing old, and they will become more expensive. Except for younger faculty starting families, the maternity costs and so on. But forget about that just for a moment in terms of other basic sort of health needs. There will be exceptions. But generally, as a principle, an actuarial principle you can take to the bank, younger folks in this system will generally not call upon it as much and are contributing to a robust insurance pool that will be mostly called upon by the older and sicker members. So why would a university want and promote a community-rated system? The young people might object. We can get insurance outside the university and we can base it on experience rating. We can find a company that will insure us on experience rating, and because we're young and healthy, we'll get a much lower rate. We'll save money. Instead of paying 7% of our income, we'll only be paying 3% of our income, or whatever. Right? But everyone stays in. The university strongly promotes it, and everyone seems pretty happy about it. Why? Well, the university has a good deal because, as opposed to the population at large, by having a community-rated plan, they're insuring only their employees and employees' families. If you're employed and are working at the university, you have to have pretty high capacity and pretty good health. If you didn't have good health and didn't have high capacity, you wouldn't be employed by the university, so the university starts out with a very good risk pool in general. They also say there's some kind of intergenerational equity that's working here. We want faculty, especially when we look at younger faculty for tenure, we scrutinize this most important decision that a university can make, as to tenure a promising young faculty member, because we expect and we hope that that individual will devote his or her career to the university and be a lifer. Not just this first 5 or 10 years, but for the next 20 or 30 after that. And that means that these smart people know, well, maybe I'm paying a little more now, and maybe the extra I'm paying is helping pay for the more senior colleagues. But hey, in 10, 20, 30 years, I'm going to be a senior colleague, and there'll be a new batch of younger people paying for me. So you create a community. You create a sense of institutional loyalty. We're all in this together. And of course, a good institution takes care of its members. And while I'm young and healthy and can contribute a little more, that's fine. So my senior colleagues who helped me, really guided me through my career, helped in my promotion and so on, they deserve to have a little bit extra in health benefits. And I am going to be in that place too, because we're all going to age. And we're all going to face additional health risks that come with aging. We are creating a sense of solidarity within this institution. Every time you have a community-rated plan that operates this way in a university or some other institutional setting, it is generally good for morale. It is generally good for a sense of solidarity. What we as a country, for reasons that we'll have to explore, haven't been able to do, but that the European countries have done very, very effectively, is take the principle of solidarity. We're all in this together. Those who can afford a little more, who are more healthy, should pay for those who need more and aren't so healthy, because we're all in this together. That's the principle of national health programs in all those advanced countries that celebrate it as a principle. They even call it by the French version of it. I won't try to spell it. My spelling function is this. Solidarité. And you will see in Reed's book how often solidarité comes up in Switzerland, in France, and other countries. It's another basic human rights principle, like the French Revolution. Liberté, égalité, fraternité, solidarité, added in the 20th century, based on this shared community-rated national health system. We have community rating, we don't have it on a national level, and in part perhaps because we in the United States are very divided, and it's very hard to imagine that we'll ever get to the place of solidarité, as in so many of the European countries, as a fundamental guiding principle of their social institutions. I'm just going to, I know that the clock is running out, introduce another principle, tell you where to read a little bit about it, and perhaps Sue Ladden will come back and refer to this before she goes on to the other topics that I was expecting her. Are you raising your hand? No, you're just resting your elbow. Okay. I thought maybe ask a question. And that's the principle of moral hazard. I think the authors are pretty clear about what this principle means and how significant it is. The best places to read about moral hazard in Shi and Sing are on pages 13 and 197. What it refers to, and what the term seems almost literally to mean, it's a kind of hazard to our morality, it can be applied very technically, but the basic reality that underlies it is the tendency of people with insurance, especially robust, generous insurance, to spend more, on in this case health care, than they would if they didn't have insurance to cover them. Because they feel, one, they've contributed substantially to the plan, they've paid in some healthy premiums, and they want to get something out. And so if they have a sense that we can get out of the insurance payment for this, that, or the other thing, there is a moral hazard that is a perhaps unwise economic decision, but a perfectly understandable human one, to take advantage of the system and have that need met through expensive services. It may be that in certain cases, a relatively simple X-ray will be sufficient, and an MRI will cost you at least $800,000 more. But suppose someone says, oh, don't worry, it's paid for by your insurance. Won't you tend to, well, let's get a better picture then. It's a little inconvenient to be in that silly tube, but, and some people get genuinely freaked out and have claustrophobia, and it's a major issue, but for most people, it's not that big a deal. It's annoying, but better images, better care, another $1,000. It's not out of my pocket. It's, of course, draws on the insurance pool. That's the general issue of moral hazard, and the sort of thing that health economists have been struggling with is if this is a real tendency that's built into our system and the way it is funded and the way benefits are structured. What can we do to try to put a curb on moral hazard to limit excess spending? And the simple answer, just to telegraph it, is co-pays and deductibles. So instead of, if you have, okay, you can get your MRI essentially for free, but by the way, there's a $200 copay if you want the MRI. Oh, well in that case, maybe I'll just go with the X-ray. And that is what economists have been, and health policy people, experimenting with in setting deductibles and copays to see what effect it has on behavior. Yes, you definitely have your hand up for a question.
Yeah. So say you are in the younger generation and you're in the risk pool, which is, generally veterans will more healthcare.
Right.
But you have comorbidities and you often have to take out from the insurance pools.
You're not gonna, your rates are gonna stay the same as
Your
long as
rates
you're
do
in
stay the
here.
same.
Absolutely. That's the beauty of it. The elderly, who more likely will be in that case, or the young people who may have some special circumstances.